Okay. So the reason that I am doing this is because I have many people asking me what is the dynamic flex cast? What's the difference between this cast and many other casting techniques? And other people sending me messages. What happens if the child has no cast? Are they going to move the same way as they are moving? And so a lot of things that are positive and some others that are like, this doesn't work. And so I will show you what is this technique, why we use it, and basically what are we achieving with the children that are working with the dynamic flex cast. So this is only information. This is not qualifying you to go and do the casting because you were taking this lecture. And it's just to give you awareness and to see how we do for this training and why we cannot teach it online, because a lot of people are asking me if they can take the class online. So, and then this is just for manipulations. The foundation of this class came from the Ponseti technique, and probably many of you have heard about the Ponseti technique, how they correct the club foot. And this is similar application, but not the Ponseti technique. The foundation is this one. It's just for alignment to prevent the children from having surgeries. So the technique that we are doing is not invasive. It's basically provide the perfect alignment from the bones to get the anatomical position and start training the child with those muscles that they don't use. So the alignment helps to control the muscles that are not firing and start performing the activities with proper and natural movement, which is easier for the child. And then we remove this tool to continue with the process that we have for therapy. So why is different from other casting techniques? I have taken many classes for casting in the United States. And I have classes with people that when I came here, they say, oh, you have to take this class. This is the guru of casting and you have to do this. Actually, I did this class probably like 3 times and I couldn't understand why are they doing the casting, providing stretching and not gliding the bones using the concave convex rule that we learn, all of us learn in physical therapy. We have a concave convex way to move, and then it's easier for the child to not have pain, to not feel stretching. And another thing that I was kind of confused is, why do I have to start wrapping or holding and then stretching? Or why some people are casting by themselves and not with someone helping? So how can you control those bones that are firing the muscle in different position and removing the position of the feet and twisting it when you need your 2 hands so the other person has to hold? When a child has excessive muscle tone and is moving in the wrong direction, it's very difficult to control all those segments. So what we found comparing what I learned here when I came and start learning this casting, then I went to start doing the modifications using the Ponseti technique, and I was like, this doesn't match. Why? Because in my technique, the dynamic flex cast is alignment for functional mobility. And the other technique was stretching because the muscles were tight. We aligned to maintain the posture. And in the other one, when I was doing the class, the alignment was not always considered. Also, I didn't like that the class was casting myself, my other student that was there, and the other person, and the other person. We didn't practice with different cases on or children. So I didn't see that as a plus. So we allow movement. The movement is under control. And it's not the material also, it's just the movement. How can we align those bones? And with the other casting technique, we immobilize. And the immobilization, sometimes the child doesn't move comfortable or they complain that it hurts. And we allow to create the movement because when we put in an anatomical position, there is a quality of movement, there is function. And with the other technique was basically increased range of motion. So we need active participation. We don't need passive stretching. We can use plaster for this technique, and we can use flexible material or we can use semi-rigid material. And with the stretching that we do, it doesn't exist. We don't do any stretching because we don't do passive stretching over time. We just align, the muscles start to work, and the range start coming over practice and exercises and repetition. So the kids, when they are collapsing with the feet, when they are standing and the feet are completely collapsed, they have difficulty to move because the knees collapse, the hip shifts in a different position, and they start developing problems any other place in the body. So with the other casting technique, is just to cast for contractures, for muscle tightness. For our technique, it's just for neuromuscular reeducation. We need to train those muscles to do better. And with the other technique that I learned, I don't see any active movement. It's just like they are casted, and what is the active movement? So we have the cast that we use, they can use for longer periods. The other casting technique, you have to change every week. My casting technique, you can change also, depending on the alignment that you get, because you don't want the child to feel pain. When you cast, the child usually is like, wow, what is this? It feels weird. And they start moving different. Like the last post that I posted in social media was a girl that I casted her, and she said like, this feels so weird. And when she stood like, oh, I feel like I can run. And so the reason that we say that we can also change it every week is because sometimes we do not achieve 100% alignment on the first cast because the bones are very rigid. In the cases that the bones are very rigid and the muscle and everything is rigidity, I try to use plaster. And then I change the plaster every 3 days, but I don't put another plaster immediately. I give the child a time to recover and perform the movements without the cast. With the dynamic flex cast, I can cast, and if I achieve 100% alignment, I can keep using the same cast until I'm no longer needed. So those are things that I always compare with the casting techniques, and we how we use it, and it's different from casting or splinting because a lot of people are telling me like, what's the difference with braces? It's a big difference. So the purpose with the dynamic flex cast is to strengthen the muscles. And with the splints, you have immobilized to provide support, and is stick is rigid, the muscle doesn't activate. So the material that is what I use is not the priority to activate the muscle. It's how aligned to promote the activation of the muscle. And with splinting or bracing, you hold in a static position, rigid materials. In my case, I can use the rigid material, but I'm not holding in a static position. I'm just promoting the bones to glide. So another thing that is important is that people think that I am against braces, and I am not against braces. I just feel like brace is only when it's absolutely needed because we need to allow movement to correct the position that the child is having as a default that limits and restricts the ability to move versus the brace, it restricts the movement and might limit muscle development. Like I see on the children that come here later that were wearing a brace since they were less than a year old, and the calf muscle is completely flat, it's not developing. So we allow control and guided movement. And the brace is you take the brace, and sometimes the child doesn't know how to walk without the brace. With the materials we use, as I mentioned before, we can use rigid, flexible, semi-flexible, full flexible, depends on what we found. And right now, because I'm traveling and teaching, I decide that it's necessary to teach this technique. So if I retire, more people are allowed to continue doing this and helping other children, because we found that also that traveling, the materials that are in different countries are not the same as the materials that we have in US. So when I was traveling and teaching, the first trip that I did was in South America, and I brought the material. When I left, I found that the therapists couldn't continue casting because the material was not the same. They couldn't find the same material. So then now we decide, let's continue doing this, but we are not going to provide the materials anymore. We are going to use what they have available in their countries. And with that material, that's why I say it's not about the material. With that material, we can achieve exactly the same goal. So early is better for children to receive this cast before they are fully ossified. I have a few classes when I talk about the development, the neuroconnection, the movement inhibition, and what are the stages for ossification, which is important also for cast. And any age can be also casted, because not always the muscles and the bones are going to continue in the same direction if we align, and we can achieve muscle strengthening. And usually the children, when they have braces, they develop more deformities, because the brace gives them redness. If the brace is giving them redness or blisters, and they start posting and posting to correct those redness and those blisters, it means the brace is not well done. So the conditions that can be done with this is like the relapsing club foot. Children that have relapsing club foot and they use this casting technique to start training those muscles again, they usually get better. The toe walking, cerebral palsy, BPI that we address also with conditions with casting, and any alignment issue. And for the traditional stretch and the immobilization is usually after surgery and post-surgical immobilization. Children who qualifies for this? Children that have need that have the need of dynamic alignment and strengthening, because it's not that I will cast you and go home. No, if the person cannot stay for therapy, normally we cast them and we send them to their current therapist, and the therapists are performing the treatments with this cast. Children that need full immobilization is usually for the ones that are convenient to use brace or different rigidity of stability, because they need full immobilization. Uh, Cases that do not qualify, the cases that need total immobilization or severe bone deformity, or children that have like tuberous sclerosis, any of the tubes, they might not qualify for this technique, because we don't want to restrict the circulation and the blood flow that is going to the heart. And children that need traditional stretching cast and splinting, dynamic muscle training with other techniques that they use in therapy, but not for the techniques that we normally use for physical therapy. The goal of the treatments that we have for dynamic flex cast is active and functional movement. If I have to cast a child that has severe deformity and it makes progress because is younger and is flexible, and we cast, then these children can go down for the splinting or the bracing that they needed. But the goal with our technique is actually provoke dynamic movement to create muscle strengthening. When I say dynamic movement, I'm not talking about DMI. It's another totally different world that we do not combine with the dynamic flex cast. The goal of treatment is active function, and basically try to send the child as independent as possible. So why it's important to align? Because we need to maintain all joints in the segments functioning properly. If the foot is corrected before applying the cast, we can position in a better alignment. We basically start correcting and we say, yes, this person is a candidate for the dynamic flex cast because we need to be sure that the foot can get corrected so the child can stand and work with the rest of the body. If the base is not under control, it's very hard for us as therapists to start controlling the rest of the body. And then we have a stable position where we can have free hands to start working with other parts. So if we keep the alignment and the root of the problem, we can avoid compensatory movements. So children that are collapsing with pronation, they have the tendency to move the leg into internal rotation. There are other children that are toe walkers and they are doing the muscle like the prick SPML, that is the percutaneous muscle lengthening. Yes, they go with the feet down, but what's happening after? Those children are standing with forward posture, severe knee hyperextension, and you didn't correct the root of the problem because you were just bringing the heels down. And what happened to the balance? They didn't know how to balance with the heels down. You have to work with the heels down before and then bring the body back for them to have success. So the priority is if you have neutral full alignment, if you have stable bones, especially the tibial bone that is the progression for when they are walking. If the hip is in neutral, if you balance all those muscles, then you can have full body activation. You can work with the core, you can work with the trunk, you can prevent scoliosis. You're going to engage all those muscles to prevent compensatory movements and facilitate the motor learning. So, in the case of the conditions that we manage, I considered many factors before I am casting, but for me is like number one client will be children with cerebral palsy, which pretty much is an umbrella that covers many, many, many conditions. Children with Charcot-Marie because it prevents for them the progression of the arch and the pain, and children with traumatic brain injury because children that suffer from traumatic brain injury, they develop muscle contractures. And the musculoskeletal conditions, basically managing the deformities like arthrogryposis and idiopathic toe walking. And my level two is to correct or prevent the progression of hip subluxation. What to consider? When we are evaluating the patients, it's not just come and learn the cast. We normally teach the students observe, observe. It's not like every patient has to have the cast. So when families are contacting me that they are interested in my services, I normally request a video of the child to see how the child moves. I will know because they request my services because they are interested in the casting. I will know, is this child actually going to need the cast or is this child going to benefit from intensive in another place? And then we start the conversations and we decide. So I consider in the lower extremity, is the child in towing? Where is the tibial bone? It's altoing. Is a tibial torsion. When are they going to be having conversations with the doctors that they need surgeries? Pretty soon. So I try to get those children as soon as possible before they start scheduling surgeries. Excessive pronation, knee hyperextension is the one that I see the most now, not only because of the therapy that the surgery they are receiving for elongation to release the muscle to get better and put the heel down. Also, some of the techniques that I see have a lot of distal hold and they are balancing and doing a lot of hyperextension that is affecting the hips. The hips are being compromised. And I also do it in the flexible foot deformity. Why do we use? Because we need to correct postural asymmetries. We need to prevent compensatory movements. We help with the muscle contractures. and the alignments. In general, we try to work with all the joints. I do dynamic flex cast for upper and lower extremities, and I use a lot of CIMT, and it has been actually very successful because those children that were with scoliosis or hip subluxation or pronated foot or toe walkers, they are all having success. So this case is a case from a therapist that I trained in Peru. So she came to my class a year ago, and the first client that she had this deformity. So the kid was actually unable to walk. So when people takes my class and they didn't have this case in my class and they have doubts, they are not alone. So she called me and she says, "This is the case that I have. Where should I start?" We never had this case in the class. And I said, "Okay." We were via camera. I always tell them, put camera, talk to the parents that I'm going to be there. You can use AirPods or something so they don't listen to the instructions that I'm giving you. And this is the result after forecast. The kid was doing the casting and therapy. And this is what you can gain in just 4 weeks of casting. This is a case of a therapist from India, and this is what I'm seeing all the time during therapy or after the surgery. Like during therapy, some children are developing this position, and in India, they have to use a different material. And this is what happened when they apply the first cast. And this is what happened after they were done with treatment. The child was actually able to stand with better posture. The knee hyperextension is not as exaggerated as is this one. It's still knee hyperextension, but it's an ongoing process. The goal was to actually work with this child with better posture. And this is another case from a patient in South America. That's how the child was, full big arch. And this is the result after two cast. And the child is completely fine. And is this cast going to be needed in the future? Probably. As the child grows, the bone is going to grow faster than the muscle and the pulling begins, so they have relapses and recurrency. It's not one cast correction, they are fine and they are never going to need the cast. They will probably need the cast in the future, maybe not as many as they need at the beginning. So this is the same, and it's just like the arch was completely twisted, and this is the changes where it goes after the first cast. Okay, this is a child that the story is very sad. It's very sad. It was my patient when I was a baby, and then they moved out of the country, and she started like she was fine. She was walking independently and everything. Then she came back and she has those braces. With braces, with shoes, without the braces, without shoes, it's the same position. So she cannot control the posture of her feet, even with support. We are basically lifting her. She couldn't walk. She's walking on her knees because it's so much pain to walk on their feet and falling that she cannot work anymore without a brace and support. And without the brace, this is how she is currently. So then we did the cast. We start doing the cast, and this is the correction that we achieved. And this is the posture that we achieved. This is after one cast. I did this cast for this girl that was my patient years ago, came to the class to be my demo, and this is what we achieved with one cast. And the mom sent me 7 days after her and at home walking like you see here, holding into furniture. She could stand better. I haven't seen her again. The people that I train are following her case, continuing with the cast. And this is a video that you guys saw on Instagram. So this is a girl that was managed since she was a baby with brace. They put an F on one side. Look how it's digging on the leg, which is not appropriate because it's actually pinching her calf muscle, and she couldn't even walk. And then in the other side, she had an SMO. So we did the dynamic flex cast. She was a demo for my class, and then she came for intensive. And this is how she ended up walking within the first cast. And now she is just running and functioning without the cast. However, she's growing and now her muscles are pulling, she's super tall, and eventually she will need another cast. And this is another one of the patients, and he is a hemiplegic case, and he was just scooting on his butt. You probably saw this video as well, and unable to walk. We did CIMT, we did his intensive, we casted his leg, and within the first week, the child started doing the first steps independently. He's fully independently. He runs, he climbs. Yesterday or 2 days ago, I received a video of him riding a bike without training wheels. And this is how he left, and this is how he started walking after we corrected his foot position because he was completely twisted. Okay. This is the last case that I saw a week ago, 2 weeks ago. This child had the surgery to correct for this posture, and a month, a few months after, her posture was back to where she was like this. And I saw her after the surgery, and the mom came, and I asked, like, why does she have these scars and this, and she says she had the surgery but it came back. So with the technique, our goal is basically to help the child to be able to move easily in this position and strengthen those muscles. And if we strengthen those muscles, there is no reason for the foot to go back that bad as it was previous with surgery. I'm not saying that surgery is not an option, but I feel like we need to pursue something that is less invasive and start strengthening those muscles instead of jumping into surgery right away. What is the benefit of this? So, improve alignment and body posture. Because as you see on my page, I have a few patients that they have like a scapula winghead or scoliosis. And when you look at the root of the problem, it's like, oof, the problem begins from here, from this alignment. We need to help the child to have functional movement, functional pattern. And these patterns for movement correct the entire body. It helps with the entire body. It balances the entire muscles. And you need to enhance muscle activation. You reduce pain, because I met a child in one of my trips that had so many surgeries and is actually walking with severe snapping back on the knee, hyperextension, that when I saw him and I looked the way that he was moving and the face, and I put my finger on the knee and I touch him and says, ow, say, it hurts you, right? And he says, yes. How did you know? Because the way that you are moving. The way that you are moving is going to cause more problems. And pretty soon, won't be able to walk with it, even with a walker. So when you have correction of posture, then you have the alignment, you have better posture, you reduce pain, you reduce stiffness because the muscles start working and activating, and you can decrease the fatigue, because children that have deformity, they don't last walking longer. They walk 3, 4 steps and they are like, mom, hold me, dad, hold me. And then they have to use assisted device. And it's important to start working early. And how to get trained. I have 2 levels. It's a level 1 that is for the short cast. Why I don't do level 1 and level 2, like one in one session and one in the other one, is because some people are doing the casting and they feel like it's too hard. They are like, no, this is not for me. I feel it's easier to brace, it's easier to do this. So I don't do it also, because I need to see a perfect foot, perfect function, children that are working on a more functional moving after this alignment, and then we can move all the joints up to go for the hip. So the level 2 for the hip has too many segments involved. So if we don't know how to do level 1 perfect, it's very hard to move to level 2. And I can tell you it's because we can break a leg, which had happened with a child that was casted with level one, and they tried to do something without having a training for level two, and the child had a fracture. So it's important to learn and to get trained well, not to just like a lot of people are doing. They're watching videos in social media and they are like, oh, I know this. I know how to do this. I can get the same materials, because I have received cases like that. That the parents came to me and they say, well, the therapist says that she can do the same, that she was trained in casting and she can use the same material as you are using. It's not about the material, it's about how do you actually create the movements following the concave combat rule for anatomical position. To get cover other areas. We have a lot of requests all over. So we will be traveling to Idaho this summer, then New York. In New York, we have a very short training, but it's going to be extensive. It's only 2 weeks. Idaho is 4 weeks, New York is 2 weeks, and then we go to Romania. And so from there, we will be in Europe training a lot of people. But if you are interested in knowing more about this, I'm very, very easy to find. Um, you can find me very easily via email, or my phone is there. If you send me an iPhone message, I don't answer. Usually the WhatsApp messages are hard for me because it's too many chats. But if you need more information, you can reach me via email. I'm pretty easy to find via email. I'm not easy to find via social media. And questions?